Just before I ask Dr. Grayson to introduce our next speaker, I just received an email from Maureen. You need to know she had a very complicated surgery that was basically 8 surgeries, all done within one 7.5-hour surgery. Very complicated, very extensive. But Maureen, an incredible person. And Maureen's brother is here. Maureen? Les, where are you? Right over here. Okay? Thank you for joining us, and we're thinking of Maureen, okay? To Jim and everyone at Halifax Conference, as I have my cream of wheat, juice, and tea served up by Melissa, one of the nurses at the London Health Sciences Centre, I'm thinking of everyone at the conference and hope for a wonderful day for everyone. My recent very complicated surgery exemplifies so poignantly the importance of the NET team. A special hello to Dr. Walter Kocha, without whose championing of my case I may not have been here today to send this email. Warmest regards.
Thanks, Jim. On that note, we'll start the second part of the morning, and I'm very happy to introduce Dr. Ali Imran, who's a colleague of mine here at Dalhousie University, where he is a full-time academic endocrinologist with us. He completed his postgraduate training in internal medicine and endocrinology in the UK and Canada, and he directs and is leader for the thyroid clinic as well as co-director of the Halifax Neuropituitary Program. Probably the most important thing to know about Dr. Imran is that he seems to never break a sweat, no matter how many miles he bikes on his way to work. And the only time I really see him is with a bicycle in hand, taking the elevators up at the QE2 Health Sciences Centre. Dr. Imran.
Thank you very much. First of all, in keeping with the Election Canada 2011 spirit, I'm just going to get a quick vote here. How many of the participants here are actually physicians? And how many are patients or patient relatives and friends? Okay, thank you very much. That actually tells me how I'm going to pitch my talk. Nurses. Apologize, I always do that. As I'm getting old and forgetful, you will have to forgive me. Thank you very much for the introduction, Dr. Grayson. I was given the talk to discuss an endocrine approach to pancreatic neuroendocrine tumors. So basically, how I, as an endocrinologist, in my clinic would see, diagnose, and then eventually at some point manage those patients. So first of all, neuroendocrine tumors, they have been well known throughout history. In fact, one of the earliest mention of neuroendocrine tumor was from the Bible. In the book of Deuteronomy, it says the Og, king of Bashan, was left of the remnants of Rephaites. His bed was made of iron and was more than 13 feet long and 6 feet wide. It is still in Rabbah of the Ammonites, so obviously it was displayed at the local museum somewhere in Rabbah. So those of you who have some interest in history, in particularly biblical history, might remember that Goliath, actually, who was a very tall individual, belonged to the same particular tribe. And you obviously might have heard of the story of the epic battle between David and Goliath. And we today believe. So, do you know how Goliath was eventually killed? Sorry? So obviously, David hurled a stone which hit in his forehead, and he died of it. But I can tell you that that probably we think that there was something wrong with his bony structure of the forehead, which was weak, because normally you won't kill a person with that. And we today believe, and I'll come back to that in a minute, we today believe that he had some calcium problems, and as a result his bones were weak. And as soon as the stone hit him in the forehead, his forehead cracked and he died. This is one of the very early pictures of his surgery being done by David. We have some we have some surgeons here, so certainly I don't want them to feel uncharitable thoughts about me. I'm positive they don't do this stuff these days. The outcome in those days of surgery was not very exciting. So that said, the objectives of our discussion today, I'm going to give you a case, which is a case-based discussion of neuroendocrine tumor. The case is a case from our clinic, someone with multiple endocrine neoplasia. You must have heard about it, and I'll go through it in some detail. I'm going to show you the current investigative options towards some of these pancreatic endocrine tumors, their limitations, and hopefully spend some time for questions and answers. So this is a case, JS. He was 39. He was referred by a locum family physician to us back in 2001, and the diagnosis was made of a condition called acromegaly. Acromegaly is a condition which is basically a pituitary tumor due to a pituitary tumor, and the pituitary tumor produces excessive amount of a hormone called growth hormone. All of us, when we are growing, we need growth hormone because that makes us tall, but eventually, once our bone ends have fused together, and if we have a tumor which is producing growth hormone, we cannot get any taller, but our body and the tissue, they continue to enlarge under the influence of growth hormone. And as you can see in this picture, this gentleman has very broad spade-like hands, and you can also see some wasting in you can see that the dip in the hand over here, these are the muscle wasting due to the nerves that are trapped in the enlarging tissue. We can also see broadening of the nose, broad jaw, and obviously you can see high cheekbones. So this guy had acromegaly. I'm not going to dwell too much on that. So in this case, we did some preliminary testing on him. And for those of us who are non-physicians here, we measured his growth hormone level and also another protein called IGF-1, or insulin-like growth factor 1, which is produced under the influence of growth hormone. And here you can see the normal levels for IGF-1, which are up to 284, and normal level of growth hormone. And in his case, his growth hormone and IGF-1 levels were both markedly elevated. And then we did some further clever testing, which endocrinologists love doing, and we eventually found that he did have a pituitary tumor with acromegaly. This was JS's MRI scan, and if I may take some time, I can show you with this. You can see this whole white thingy. That is a huge pituitary tumor. Normally the pituitary sits around about here. This big enlargement is the mass. These two black dots are your internal carotid arteries, which supply the blood to your brain. And this structure, which is sitting on top, this stretched structure, these are your eye nerves, which basically control your vision. And this tumor, as it grows, it kind of gradually pushes on your eye nerves, and it can sometime, unfortunately, cause blindness. So anyway, he ended up under the surgeon's knife, not the surgeon I showed you earlier. Surprisingly, our surgeon's name is David Clark. So a bit of coincidence there, but he did a marvelous job. And you can see this is the MRI after the surgery. And these are the optic nerves which I was showing you, which was all stretched initially. They're all cleaned up, and the tumor is pretty much gone. And after the operation, his IGF-1 levels, which were significantly elevated, the protein we measure for growth hormone, they had normalized, growth hormone had normalized. And unfortunately, as you know, pituitary produces several other hormones. One of the hormones which pituitary produces controls your sex hormones, and that being testosterone in men and estrogen in women. So in his case, there was some loss of pituitary function, and he became testosterone deficient, and we ended up putting him on testosterone replacement therapy. So we thought that was great. We had done a wonderful job. We had cured him, and we said, we'll keep following you. That's fine. He presented again in 2003, and this time he had nausea. And at that time, the physician started testing his. He tested his calcium, apart from several other things, and his calcium level was elevated. Normal calcium level is up to 2.6 millimole per liter. His was 2.93 millimole per liter. And then one of the major hormones that controls your calcium is parathyroid hormone. And parathyroid glands sit here behind your neck, behind the thyroid gland, and they control your calcium. And as your parathyroid hormone actually increases your calcium level. Now, in his case, looking at the blood test, we could see that his calcium was elevated, and looking at the parathyroid hormone, I won't bore you with the feedback loops because that's far too complicated for most of us. So the bottom line is, looking at the test, we thought that he had a parathyroid gland tumor, or an adenoma, we like to call it. But these are benign tumors, and I thought that he ought to be investigated for that. But at the same time, as soon as we saw two things, i.e. a pituitary tumor followed by a calcium disorder, the bell started ringing. Does he have multiple endocrine neoplasia syndrome? And that is when we sort of started investigating him. So you must have heard already about what MEN is. It is an autosomal dominant condition. In other words, it is if one of your parents has this disorder, you have at least a 50% chance of inheriting this disorder. That's what autosomal dominant means. It is located, the gene for this particular disorder is located on chromosome number 11, and that's all the molecular stuff that I'm going to tell you here, the genetic stuff. MEN, typically, we call it a PPP type of tumor, P for pituitary, P for pancreas, and P for parathyroid. So in this condition, people generally present with a pituitary tumor. They have parathyroid problem, which controls their calcium, and they have pancreatic problems, and eventually, and some of these have a carcinoid tumors. And I'm not going to go into carcinoid. You're going to hear that, and you've already heard that from other eminent speakers here. So basically, P for pituitary, P for parathyroid, and P for pancreas, and those were the things that we needed to investigate him for. Typically, what happens in MEN1, not all patients have all the features of the disorder. Some people may have pancreatic problem, pituitary problem or parathyroid problem, not necessarily pancreatic problem. It depends. And the other important thing is that different abnormalities of this syndrome, they appear at different stages of life. So, for instance, these are your years of life, 15, 16 to 20. These are divided in terms of each decade. And you can see that most of the problems, they occur somewhere after the second decade. And then, and by the time you are in your 40s and 50s, almost, you're guaranteed to have at least one or more of these problems. So if you look at these problems, so parathyroid problems, they occur roughly in your 20s and 30s. Around the same time, you'll get your pancreatic problem, particularly Gastrinoma and insulinoma. Don't worry about it. We'll come back to it. And your prolactin problem as well, which is a pituitary problem. Excuse me. And then there are these are all 94 to 95% of these patients have parathyroid problem. About 30% of these patients will have pituitary problem, and about 40% of these patients will have pancreatic problem, which basically I was telling you, not everybody is going to get everything. So coming back to our case, because we did some further investigations and eventually we found that he did have parathyroid abnormality, and as a result there are typically between 3 to 4 parathyroid glands. And in his case, he had 4, and out of those 4, the physicians removed about 3.5, leaving 1 behind, hoping that half of the gland will continue to keep his calcium in the normal range. Otherwise, if you remove all the glands, then you end up putting those people on calcium replacement, which is not very pleasant. So we did that, and luckily his calcium has remained normal ever since. However, we had a rather, as we call it, kick in our teeth, in the sense that when we did the genetic testing in 2004, it was reported as negative. Now that was quite a bit of a surprise for us, because this was someone who had 2 of these rather rare problems. Remember, pituitary is a rare problem, parathyroid is a rare problem, and it generally we tend to having 2 rare problems in one person is a bit unusual, unless they're part of a syndrome, which in his case the genetic testing was negative. But a negative test does not rule out multiple endocrine neoplasia, because at this point, if I had done your testing 10 years ago, we knew about a certain number of genes, a genetic mutation that would cause MEN, but now in 2011 we have discovered several more mutations. So what were regarded as quote-unquote negative in 2001 may be positive now, and maybe another 5-10 year time we will be able to retest our patient and find that the patient actually does have a positive mutation. Now, why it is important? It is important because if we know the mutation, then, because I told you it's an autosomal dominant problem, then we can go after the family members and find out how many of the other family members, and children in particular, have in fact inherited this mutation, and we can then do preemptive measures to deal with these tumors before they even occur, start causing any problem. Now, at that time, because by that time we were waiting for all these tests, we decided to do a CAT scan of the abdomen, and interestingly, there was a pancreatic growth. So now we have someone who has 3 problems of 3 P's. We have someone who has got parathyroid problem. We have someone who has got pituitary problem. We have someone who's got pancreatic growth, and yet the genetic testing is negative. So now we had to go after this thing through clinical investigations, and to find out if truly this is a problem. So going back to our case here, and I'm going to bring all these into perspective in a minute. I asked this patient about these particular things: diarrhea, flushing, syncope, sweating, weight loss, hyperglycemia, which means high sugar, and a skin rash. And I said, I'll tell you why I asked that. None of those turned out to be positive. If you were to go back to the slide which I showed you initially on the pancreatic problem, the most common pancreatic, so every time we see someone with a pancreatic growth in the context of multiple endocrine neoplasia, MEN1, we have to do 2 things. First of all, we have to find out, is this a functioning growth? In other words, is this a hormone-producing growth, or is it a sort of a non-hormone producing or non-functioning pancreatic growth? If it is a hormone producing growth or a functioning growth, then we have to deal with it separately in another way. If it's a non-functioning growth, we deal with it in a completely different way. So of the functioning growths, the three common ones are gastrinomas, and I'll talk about that, insulinomas, I'll talk about that, and vipomas, and I'll talk about that. The rest are rare as hen's teeth, so I don't want to waste your time telling you about things that are, you see one in 2 million individuals. So the first question I had to ask myself, is it a gastrinoma, or is it a gastrin-producing growth? Let me just give you a little background on what gastrin does. So gastrin is what controls your stomach acid production, and essentially there are gastrin-producing cells both in the pancreas and to some extent in your stomach as well, and basically they help control. So there's this gastrin which, through some of these fancy pathways, they lead to production of increased acid, so HCl or acid production, and as a result, under normal conditions, in a normal individual, when your stomach becomes too acidic, what happens is the message goes back to your pancreas that there is the acidity level of your stomach is rising, so your gastrin production will be switched off. But in people who have gastrin-producing tumors in their pancreas, the tumors do not respond to that sort of message coming back. They keep producing excessive amount of gastrin no matter what, and as a result, your acidity level of the stomach keeps rising and rising and rising. And you know what acidity does. If you don't, then you can always go home and take a bottle of HCl, and you'll find out. So in this case, as I said, these gastrin-producing cells, they exist in stomach, in the duodenum and pancreas, and that's what happened. So what is a gastrinoma? Gastrinomas they were described in 1955 by a couple of clever guys by the name of Zollinger and Allison, and they actually present with severe ulceration. As I mentioned, acidity means ulceration. So because of this excessive amount of acid in your stomach, the stomach lining gets ulcerated. Most patients are diagnosed between the ages of 20 and 50, and that's what I showed you from the graph before. And as a result of this excessive ulceration, patient present with abdominal pain. Obviously, people who've had ulcer know there's abdominal pain, diarrhea. Because of this acidity, all this acid spills into your large intestine, and then it causes diarrhea from there, and nausea and heartburn. And this is how it looks like. These are kind of ulcer craters. They look like eaten away and white inflamed tissue, and these basically are how they look like. So how do we know? How do we tell if it's a gastrin-producing tumor? First of all, we measure your fasting serum gastrin or blood gastrin level, and in a normal individual, your normal gastrin would be under 50 picomole per liter. If your fasting gastrin early morning is over 500, it is virtually diagnostic that you have a gastrinoma, because such high levels will not occur in the absence of gastrinoma. If on the other hand, if it's somewhere between 50 and 500, that can occur in people who have stress and whatever. So in those cases, we do certain clever tests to actually see if it is an abnormal acid production. And one of those tests is called the secretin test. Secretin is a hormone which in normal people will induce the production of gastrin, but in people with gastrinoma, it will excessively induce gastrin secretion. In other words, if in a normal person, if I gave you secretin and your gastrin level goes up by 50%, just for argument's sake, in someone with gastrinoma it might go up by 100%. That's how we can tell one from the other. So in this case, gastrin level, if goes over 100 picomole per liter, or it increase by more than 100 picomole per liter, is significant. And sometimes we do calcium test, which also does the same thing. Unfortunately, secretin is not available easily in Canada, so we end up doing calcium test because of its relative ease. And this is how, in a normal person, if I gave them, some of you a secretin, this is what will happen to your gastrin. But if you had a gastrinoma, you will have this sudden peak and increased production of gastrin. So in our patient's case, his fasting serum gastrin was 104, which was kind of not below 50, but sort of in the gray range. And when we gave him calcium gluconate, because we did not have access to secretin, it went up to 134. So it wasn't really exciting, nothing to go to town about. So we didn't think that this was a gastrinoma. The next thing is an insulinoma, in other words, in an insulin-producing tumor. Now, insulin, lowers your sugar. People who have diabetes take insulin, so it lowers their sugar. So if you have an insulin-producing tumor from the pancreas, then that's going to lower your glucose. So this was first described in 1927. Most patients are diagnosed between the ages of 45 and 55. And those of you who have had the opportunity to miss their meal and exercise and know their sugar levels are dropping, and some of us who worked in the hospital have been on night calls, we are all too familiar with that. So you begin to feel confused, you can start sweating, you feel shaky, fuzzy vision, and you want to go and eat something because you know that you're not feeling well. Typically, these patients feel better after eating something, they can, or the snack. Now, it is important that a lot of people actually feel that, but you have to fulfill what we call as the Whipple's triad, or Whipple's criteria, and there are three. First of all, in order to label someone as having hypoglycemia, you should have classical symptoms of hypoglycemia, which I've just described. Number two, these symptoms should be accompanied by a low sugar. So if you have classical symptoms, but you test the sugar, and the sugar is like 5 or 6, which is in the normal range, that's not a hypoglycemia. You have to have symptoms plus low sugars, and the symptoms should resolve when we normalize your sugars. Then and only then we can make a confirmatory case of hypoglycemia. So if the fasting sugar, because insulin lowers your sugar, if it is less than 3, in normal individual morning sugar is about 4.5. If it is less than 3 and insulin levels are high, then we can make the diagnosis. Or we do a particularly unsavory test where we bring these patients into the hospital, we admit them for 72 hours and don't give them anything to eat, access to free water, because and the reason why if you have excessive insulin production, eventually your sugars are going to drop, and we can test that. Or we can do calcium stimulation test, which also not only increases your production of gastrin but also increase the production of insulin. So in our patient's case, he did not have any confusion, no shaking, no syncope, no sweating, no palpitation, no hunger, no vision change, none. And his fasting blood sugars were 6.1, 5.8, and 6. And he quite rightly told us to get lost when we gave him told him the concept of 72-hour fast. So that was so the next question is it a lipoma, vasoactive intestinal peptide producing tumor? So I'm still looking at whether this pancreatic tumor is functional. These are exceedingly rare, about 1 in 10 million per year. Again, most patients are diagnosed between the ages of 30 and 50. Vasoactive intestinal peptide causes diarrhea, and this is not any diarrhea. This is diarrhea like no one has ever seen. This is like watery diarrhea, and once you've seen it, you won't forget it. And to the point that you start losing potassium, so it's typically called watery diarrhea with low potassium. You can also have flushing and dizziness, and of course muscle weakness, because those of us who've had the pleasure of having the diarrhea at some point, know you can certainly feel weak if you've had food poisoning. So that is why it happens. And how to confirm it? Well, you measure serum vasoactive intestinal peptide, and if you have typical symptoms and VIP levels are over 75, in that case, you confirm your diagnosis. Our patient did not have any diarrhea, and his fasting VIP level was 19, so that was the end of it. We did not have any of those problems. So eventually, after getting sick and tired of our constant testing, he decided to have the operation done. Partial pancreatic surgery was done in 2006. by a colleague of ours who has now gone back to the Netherlands. He used to work here, and it turned out to be a non-functioning tumor. So in other words, this was not a hormone-producing tumor, it was a non-functioning pancreatic tumor, and there were no cancerous features in this particular tumor. So we're quite happy with that. So at this stage, our patient has a normal calcium, fasting gastrin, insulin, everything else is normal. Could he still have MEN1? Oh, you bet, he could. So what are we doing now? We are following our patient with, and he also has children, so they are being followed as well. And we are now going to, we keep, every few years we go back to our genetic colleagues and ask them if any new mutation has been identified, so we can go back and recheck him. We keep checking his calcium, prolactin, which should be tested in the family members, because the commonest pituitary tumor in these people is a prolactin-producing tumor. We check their fasting. This is how we follow our MEN patients. We check their fasting, glucose, insulin, their gastrin. We continue doing their MRI scans, pituitary MRIs, and all this sort of stuff. So these patients, if the genetic testing is negative, you have to follow them, you have to follow their family members. It can be quite a tedious business. So that is how we have been following. So going back to my case of the biblical case, we think that the patient had a pituitary tumor. That's why he was a growth hormone producing tumor. That's why he was so huge. He was so tall and big. And the other thing was that he had calcium disorder, most likely because the moment he got hit on the forehead, his skull cracked and he fell. And you saw the autopsy being performed later on. And in the end, those of you who don't know about this aspect, I'm also a watercolorist, and I sometimes in my free time I do a bit of watercolor. These are waterfall, I think painted in 2008 or 9, close to our home. This is the Truro Valley. I was cycling through there several, maybe 2-3 years ago. This is a lighthouse near Maine, and this is a lovely stream not too far from where I live, in a village called Herring Cove here. So I think I'm done. Thank you very much. If you have any question.